Welcome everyone, and thank you for joining us for the fourth session of the Leveraging Midwifery-Led Care to Address Disparities in Equity in Medicaid virtual learning series. I am Jennifer Moore, the founding executive director at the Institute for Medicaid Innovation. Before we begin today's session, we'd like to thank our funder, the Yellow Chair Foundation, for their commitment to advancing important maternal health topics, especially in the Medicaid population. Through their generous and ongoing support, we are able to offer this free virtual learning series. Session 4 marks the midpoint of our series. Together, we have learned about high-value, evidence-based maternal models of care and birth equity, value proposition for midwifery-led care in Medicaid, and licensure, credentialing, and contracting in Medicaid. Today's session will focus on the operational components for midwifery-led care in freestanding birth centers. Future planned sessions will explore how midwifery-led care can be aligned with state-based initiatives to improve maternal health, and how to build the business case for this model of care. You may also remember that the topics and content of our final two sessions will be informed by you. As we reach the midpoint of this series, it is now time for you to tell us what topics and content you want to learn about during these last two sessions. The topics listed on this slide have been developed in response to data collected from this series registration, session evaluations, participant questions, and individual conversations with many of you throughout this series. The options that we have listed here are one state's journey from beginning to now, lessons learned and future opportunities from the perspective of multiple stakeholders within one state, levels of maternity care and the implications for midwifery-led care and implementation in the Medicaid population, consumer perspective and demand for midwifery-led care and the role of advocacy organizations, vicarious liability, including physician oversight and state regulatory requirements, medical billing and reimbursement, the opportunities and barriers, value-based purchasing and alternative payment models, including payment reform for midwifery-led care, a roadmap for success, including action steps for launching high-value, evidence-based maternal models of care, or other topics that you can fill in. Today's session evaluation will be emailed to you, and it will include an opportunity to select your top 3 choices from the ones listed on this slide. Now, returning back to today's session, our 2 panelists will provide information relevant to 4 main learning objectives that build upon the required activities that you completed before this session. They include identify best practices, lessons learned, challenges, and opportunities from leaders and innovative midwifery-led models of care, identify the requirements for creating and operating a licensed, fully accredited, Medicaid contracted freestanding birth center, identify the similarities and differences, pros and cons between traditional freestanding birth centers and an FQHC-based freestanding birth center. And finally, identifying how innovative midwifery-led models of care are addressing disparities in their community and supporting birth equity. However, before we get started with the panel discussion, my colleague Chloe Baxt will review a few housekeeping items.
Good afternoon, everyone, and welcome to session 4. I'm going to review some details for today's session along with a few reminders. First, today's session will be recorded and archived on the IMI and CHCS website. Except for panelists, all lines will automatically be placed on mute. During the meeting, the chat feature will be disabled for all participants. We have reserved 15 minutes at the end of the panel for you to ask questions of our guest panelists. To participate in the discussion with the speakers, please use the Q&A feature to submit your questions and comments. Please submit the questions and comments throughout the session. The questions will be consolidated and shared by the moderator during the Q&A portion of the panel. At the completion of the session, you will receive an email message with a link to complete a short 5-minute evaluation survey. As a reminder, completion of the evaluation is mandatory as part of your participation in the learning series. We actively review and incorporate your feedback into our future sessions. Today's evaluation is particularly important, as Jennifer mentioned, as we will be using your feedback to structure sessions 7 and 8 of the learning series. We look forward to hearing your thoughts in today's evaluation. Finally, all the materials will be made available to you on the IMI and CHCS websites about 2 weeks after the presentation date. Dr. Moore, I hand it back to you.
Thank you, Chloe. Today's panelists will provide us with an in-depth understanding of the operational requirements for midwifery-led care in freestanding birth centers. The conversation will highlight best practices, lessons learned, challenges, and opportunities from their unique perspective of a panelist. As previous panelists have shared, there is a range of types of midwives, settings, and services that a midwifery-led model of care can provide. We have heard about CNMs, CMs, and CPMs who practice in the hospital, birth centers, and in homes. We have also learned that they provide the full continuum of services across the lifespan, ranging from family planning services and cancer screenings to menopausal care. However, today we are focusing on midwifery-led care in freestanding birth centers. And now I'm pleased to introduce our esteemed panel. First, we have Ebony Marcel, who is the Director of Midwifery at Community of Hope, of which includes the Family Health and Birth Center and FQHC. Formerly the Administrative Chief of Midwifery Services at MedStar Washington Hospital Center, she completed her nursing education at Georgetown University and midwifery training at Thomas Jefferson University. Last year, she was inducted as a fellow into the American College of Nurse Midwives and is currently pursuing her doctorate degree at Frontier University. Second, we have Amy Romano, who is the founder and CEO of Primary Maternity Care, a consulting services company focused on first-line care in the community and care for low-risk birth. With a clinical background as a nurse midwife, Amy has spent her career working on system reform and care model innovation. Previously, she led the development of clinical wellness and quality management programs for Baby & Co., a multi-state network of birth centers, and in 2020 helped lead the development and launch of the Jazz Birth Center in Manhattan, which was established under emergency orders from Governor Cuomo to expand birthing center capacity in New York City during the pandemic and beyond. Amy has also published many peer-reviewed articles and book chapters on evidence-based maternity care. So let's jump right in. It would be great if each of you could give us a quick overview of the birth center or centers that you have previously engaged with and are currently leading, including the location, types of services, and clinicians along with support staff, payer mix, and the engagement of the community. Ms. Marcel, let's start with you.
Now you might have to go back with that list. That was a long list.
I'm happy to check them off with you.
So I am at Family Health and Birth Center in Washington, D.C. I have a long history with this birth center. It was my last stop for training in school. It was my first job out of school in 2008. I left for 5 years and then I came back as the director, and I've been the director now for almost 6. So long history with Family Health and Birth Center. In 2012, they were acquired by Community of Hope, federally qualified health center. And so what also makes my experience very unique is that I was with the birth center before it was attached to the FQHC and what it was, what it has become being attached with the FQHC. Payer mix, we are, these are not hard numbers, but around 95% Medicaid. And between the two sites that the midwives see the majority of patients is 95% Black. What else did you want? Payer mix?
Types of services, support staff and clinicians. And I think really what's incredibly striking about the work that you're leading is the engagement of the community.
Absolutely. So we are able to provide, I feel like, a very unique model in the sense that here we are, birth center housed in FQHC. All the midwives have hospital privileges, so we're able to offer birth center or hospital birth. We have care coordination, we do centering pregnancy, we have integrated behavioral health. And also too, being attached to FQHC means that we are also attached to primary care. So our families have the opportunity not only to, the midwives do a lot of newborn care, but then transition to our family providers. And then a lot of families continue their entire care with our primary family practice docs.
Mm-hmm.
Other things that make us unique is that we have strong cultural congruency, which is also very hard to kind of find a lot of days and a lot of different midwifery practices. And so Out of the 10 midwives, 9 of us are, excuse me, I'm sorry, 8 of us are BIPOC, and that's really rare currently. Other things that kind of stand out about us is we are really, really working hard to practice and use a reproductive justice framework. And so how that breaks down is looking at our policies, making sure that our policies are patient-centered and not punitive. And we're just going to continue to be innovative. So I have had a really, really lovely time in this role, and really, really can't talk enough about how lucky I am for the leadership that I have that really have allowed me to create what I think is what needs to be the answer for Black maternal health.
Great, thank you. Ms. Romano.
Thank you. Hi, thank you, Dr. Moore. Thanks, Ebony, for sharing about your experience. Mine is a little different because more recently I've been involved in a more limited way in the startup phase of a number of different birth centers, including the one you talked about at the, in my introduction, which was the birth center we opened in New York City as part of the response to the pandemic. But I also spent 4 years in a network of birth centers, which was really the Baby and Company, which was the largest to date effort to really aggressively try to scale the birth center model. And so that was a private equity funded initiative. So obviously sort of for-profit model. And what we were trying to do was to partner with different health systems in different regions of the country, and we were in multiple states, develop a very integrated model with a lot of kind of clinical integration and joint quality management, as well as privileges for the midwives at the hospital, and ultimately increasing integration with additional physician services and other types of services. And we across that network, we had birth centers that didn't take any Medicaid and some that were majority Medicaid. And that had to do really largely with kind of the state situation. And also, frankly, the fact that it was a for-profit endeavor. And so we were really trying to work out the Medicaid strategy to figure out how to really be able to either achieve the right payer mix in existing centers or have the right relationships with payers so that it could be financially viable at higher rates of Medicaid, at higher rates of Medicaid population served through the birth centers. So we were sort of spending a lot of time looking at that while navigating Medicaid programs in different states. So just to get more recent with the birth center in New York, that birth center was about 50-50 Medicaid and private insurance. And so what the situation was there, and I think one of the videos that was made about that was part of the pre materials. So, but New York City has, and New York State has some of the most kind of restrictive regulatory environment for birth centers. And as a result of that, there's been very few birth centers in New York City and in New York State. In the pandemic, the certificate of need requirement, which is the most restrictive part of it, was really streamlined, and basically you could skip right through the certificate of need process and get expedited licensure for birth centers if you already held a license in the state as an Article 28 facility, which is their regulatory structure in New York. So there wasn't a huge opportunity to grow birth centers, but there was one opportunity because there was one licensed and accredited birth center in New York City, which was the Brooklyn Birth Center. So they saw the opportunity, obviously, to try to expand because they were, getting just order of magnitude more inquiries at the peak of the pandemic, just hundreds of calls a day. And so a team kind of formed very quickly, and Every Mother Counts brought some financing to the table. And that's how I got involved to help just recruit the clinical team, get them onboarded, help set up the space, help set up the hospital relationship and transport protocols and things like that. So, and that birth center, as a result of there being so few midwives in the city with birth center experience, we really had to rely, and COVID was happening. So people were out, even at Brooklyn Birth Center, people were out sick, and everything was just under a lot of stress at the time. So we relied quite a bit on out-of-state midwives to come and help with those early months to just get the birth center off the ground and operating. And the birth center is in the process now of transitioning to permanent staff, and they're hopeful to continue to add additional locations throughout the New York City area. But it's CPMs don't have licensure in New York, although under some of the regulatory stuff that was short term, it would have been possible to have CPMs in birth centers and home birth during the executive order timeframe. But CMs are pretty common in New York City, and CNMs, so that we had a mix of both. And actually, we do have 2 CPMs on the staff, but they are also they also have additional CM or CNM in one case. So, and then the prenatal, like all of the stuff that Ebony talked about, kind of the overall primary care integration and prenatal care models and stuff, we did a lot of that work at Baby & Co. There was less of a focus on that in the startup phase of Jazz, and they're in the process now of kind of improving upon the full program of care. It was really about getting another birthing facility open in those first weeks and months.
Great, thank you for that. Now let's go back to Ms. Marcel, and you had mentioned the transitions between the different centers, and what our audience may not know is that for a period of time, the birth center actually went dark, and you were brought in to lead the resurrection of that birth center. And it would be really helpful to understand your strategies that you implemented to enable that success. How you worked with the community, Medicaid stakeholders, such as the health plans. And then also, you speak to the recruitment of BIPOC midwives and your strategy around that, and why that was important for the success of the relaunch of this birth center.
Sure. So, funny enough, the reason why I ended up going back was not because they sought me out at all. I actually sought them out, but it was seeing an old patient, because women of the community, they always remember you, always. And, I always kind of say that I channel my granny midwives, ancestral granny midwives, and, they were more than just the folks that caught babies. They were community leaders. They were part of folks' families. And I feel the same way in DC. And so an old patient really, really was part of the reason why I ended up going back. Lucky enough, the leadership entrusted me to kind of work on reopening the best way that I saw fit. And it included getting back into the hospital first, and then reopening the birth center about 16 months after I had gotten there. And so when I went back, things that I noticed was a lot of the patients that I remember from before were not coming anymore. And I noticed the environment, the energy felt very different. And I listened. I would see folks in grocery stores. I would see folks in just wherever, and just kind of say, hey, what happened? Like, you always used to come to the birth center, and really hearing from them how they weren't seeing people that looked like them. They were distrustful, and how, structure, because definitely the birth center before the FKHC did not have as much structure. So that was a huge, huge challenge, because with that structure comes kind of like that very sterile framework that doesn't always feel good to BIPOC individuals. And so basically, I realized that it was going to be really, really important to hire midwives who definitely reflected the community. What was easier for me than maybe someone else is that I have always mentored pretty much since I became a midwife. So I had a pretty decent kind of like Rolodex of folks that I have stayed in contact with from when they thought they were interested in becoming midwives, and to them finally going to midwifery school and getting their first jobs. I have trained a lot of folks in the DC area. I started training pretty early in my career, and then just really, really prioritizing, that in my hiring model. Now, did I have that conversation out loud in the beginning? No, I didn't. I just kind of did it and saw the benefits of, folks starting to come into the office saying, I heard that there's a Black midwife here. I want to be on her schedule. I started to see the growth from, just from word of mouth. Because definitely in the Black community, we are a word of mouth, people. And so, I started to kind of hear just different whispers in the grocery stores or being approached by different folks. And so um, I think the key was I had a leadership that was very supportive and me being unique and innovative in how I got us back and how I structured it and how I prioritized it. Somebody else might have opened up the birth center first and then went back to the hospital. I knew that was going to be really important for just our ongoing growth, especially since the majority of our patients do deliver in the hospital and not the birth center, in addition to having that backup support. And then also things like policies, like looking like, hey, we have a pretty strict late policy, which most healthcare institutions do, but looking at, no, we're not turning away late patients. No, we see all late prenatals, we see all babies, and also setting up workflows with our care coordinators to organize not only their visit times, work on rides, when they miss, calling to follow up. Hey, you didn't come in for your appointment. Do you need me to reschedule you? Do you need help getting here? Just adding in all those different pieces were not really like textbook. So I really, really attribute a lot of our success to having a leadership that really, really trusted me, believed in me. And then also, as far as like the contracts with the MCOs, I had nothing to do with that. Our VP of Health Services is incredible. And she has gone to bat to make sure that we are getting our reimbursement. Is it what I feel like it should be? No. Is it better than some? Yes. Should it be better? Absolutely. Because I feel like we're providing high quality care, high touch, and nowhere near are we getting reimbursed what we really should be getting reimbursed. And so, yeah, I really, really think it comes down to having a leadership that really believes in trying different things, being innovative, really acknowledging health disparities and the linkage to racism, the importance of cultural congruency, and community involvement, listening to the community, looking at our systems, our policies, how folks are engaging in care, all of those different pieces, I think, contributed.
Yeah, and someone who has lived in DC through this trajectory that you're describing, you are that leader and trailblazer, and it's been really inspiring to see you make that transformation in the DC community, and it's incredibly, like I said, inspiring and impressive.
Thank you.
And it's been an inspiration for so many midwives around the country too. Ebony, you've been more than a mentor to people, but truly an inspiration and a model that people can look at. So there's just such a flourishing right now of Black-led birth centers going. And I know it's a lot of people that are involved in making that happen, but it's really awesome.
Yeah. Ebony Ms. Marcel is the poster child for this. And we're grateful that you've joined us today for this learning series. So let's shift our attention now to the unique experience of rapidly starting a freestanding birth center from the ground up in New York City as part of the COVID-19 response efforts. Ms. Romano, you helped provide guidance for the birth center, including navigating regulations and health system partnerships. Based on what you have experienced during the pandemic, How have the freestanding birth center regulatory changes impacted access to care and health equity?
I wish I could say that there's been more change. I think other than in New York, we didn't see a lot of, large scale change to birth center regulations, although I would say there's a acceleration in interest in birth centers. And, this learning series is one of many examples of that increased interest. And I think an increasing recognition that the regulatory environment, at least in many states, is really the key barrier to scaling the model or even introducing the model. In some states, there are quite a few states that have no birth centers or just one, that's not accessible to many people around the state. So a couple of the projects that I'm working on currently hopefully will provide some tools to modernize birth center regulations and so on. I'm working with the American Association of Birth Centers currently on developing model state licensing regulations that states can use to either introduce licensing in the 9 states, I think it is, that don't have birth center regs at all, or modernize them in the places that have restrictive birth center licensure. So those are forthcoming later this month, actually, on the 27th, they'll come out. But I think, there was, as far as the experience in New York, it really was the ability to fast track, not just the ability, but I would say multi-stakeholder commitment and leadership from the very, very top. It was very clear that Governor Cuomo himself wanted to see this happen. There was a commission that came together to look at COVID-19 issues related to pregnancy. And there was an awareness that a lot of people had a fear of going to the hospitals, and the hospitals were in fact dealing with surge situations and really weren't necessarily safe, at least for a period of time for patients, of any type. And all kinds of accommodations were being made for other types of patients, and really not a lot of coordination around pregnant patients, who are the most commonly hospitalized population. So there was, they quickly recognized this issue and brought together, leaders throughout the state to try to work on it. What they recognized is that the state had already done some work to smooth out and simplify the process for midwife-led birth centers, because basically the existing regulations were really required you to be a physician to open up a birth center, and also were just very costly with all of these things, all of these requirements that are much more appropriate for complex facilities doing other kinds of things. So just having that simplified and having people already at the Brooklyn Birthing Center who understood the regulations, because it wasn't like they all went away. They just, again, sort of made things faster and waived certain requirements. So that really made a difference, but it's still a huge amount of work to open up a birth center and go from square one to delivering babies safely. And it helps a lot to have another birth center that you can, we did at the beginning kind of share staff across the 2 sites and had things like guidelines and patient forms and an EMR, those kinds of things in place. Although I will say that birth centers are just chronically under-resourced, especially those that hold it as a part of their mission to serve Medicaid because of the lower reimbursement. So it was just very clear in the moment that we were asking this model of care to suddenly respond to the capacity for a city in crisis, when they've been just chronically uninvested in and disinvested in for a long time and kind of marginalized. So, and we're under stress with, staff that a lot of the staff were also doing home birth, and there was as much of a demand as there was for birth center, there was even more demand for home birth, people that just didn't want to leave their homes at all. So some of the staff kind of went and responded to the home birth needs. So they were very thinly staffed and just had a lot of kind of just general capacity issues that made it not as easy as just copy paste one birth center and open it. So, I mean, it was a pretty grueling few months of just really trying to get all the pieces to come together, but it did. And I think the experience of having built and replicated a model of care and operated it in multiple locations, and it really did help in terms of having just tools, things like clinical drills and clinical guidelines and training, ideas of how to onboard people into the model of care and so on. So it was pretty wild, but.
Yeah, thanks for that. Well, let's build on that a little bit, because you mentioned the regulations, and as noted earlier, the New York governor publicly recognized the importance of access and coverage to high-value evidence-based maternity care, which was and the focus of that was midwifery-led models, and he explicitly removed regulatory barriers that allowed this to happen. However, these changes, like many during the pandemic, are considered temporary. As you consider the important role of the birth center, its impact during the pandemic, and the relationship to birth equity, what do you think it's going to take to sustain access and coverage to these services after the pandemic?
I think, and I know there are other sessions that will go more into this, but definitely increased reimbursement, especially from Medicaid, and also just more standards around reimbursement, because there's so much complexity in contracting as well. And there's, unlike hospitals that have DRGs and specific ways of charging for the hospital facility component, in birth centers, there's basically every contract does it differently, or may as well be that way. They're all kind of a special snowflake, and because there isn't an analogous set of DRGs or code sets. So that's part of another project that we're working on with some people on this call to bring forward some more kind of standards for setting up contracts and for establishing pricing and so on. And that will be coming out later in February. But I think I think getting CPM licensure and CM licensure in the states that don't have it would be, because there are CPMs for sure, and probably some CMs in just about every state in this country. And many of them are in fact already practicing without licenses. That's true in my state in Connecticut. In fact, it's the only home birth option in this state as of this week. And so I think getting CPMs, it's a faster way to get trained, and also just could provide access to a number of people. Getting rid of the certificate of need requirement would be probably the #1 regulatory change, and it's still not gone in New York, except for under the temporary situation. And one of the other things that came about during Cuomo's commission was that the state had already tried to simplify the midwifery birth center regulations. And I started to explain this earlier, but they hadn't implemented the new legislation that had passed a year or two prior. So there was a legal concept of a more limited midwife-led birth center that wouldn't have all of the same rigmarole of regulatory requirements, but they hadn't set up the actual application process and rules and so on to make it so that a midwife could actually apply for that. So they also fast-tracked the work of implementing that, sort of while they also were enabling this unique opportunity with the one licensed birth center in the city. But there's still no additional birth centers in the state licensed under those rules, because they still require a certificate of need, which has just very extreme requirements around financing and facility requirements and documentation, things that cost tens or hundreds of thousands of dollars just to get together before you can even get a license to open up your birth center. And then you got to get patients and get them born, those babies born, so you can do your billing. So there's the economics of it make no sense at all. Nobody in their right mind, except crazy people like us, would keep trying to open birth centers, because it doesn't, it requires a lot of financing, and the timing of the payments is challenging. But I do think, kind of thinking of relatively straightforward things, maybe even things that wouldn't require new laws, but could be done with kind of administrative and regulatory or Medicaid things. I think looking at how you set prices and overall increasing the prices, and allowing CPMs and so on, and then getting rid of the more restrictive parts of the birth center regs.
Thank you for that. And just for our participants to know, Ms. Romano has mentioned an upcoming webinar and also a report that will be released in February. We'll make sure that we include that in our email conversations with you to ensure that you have access to those resources and can participate in that webinar and also obtain that report that is forthcoming. Now let's shift back to Ms. Marcel, and we've mentioned that the birth center is linked to a federally qualified health center, FQHC. The organization is actively engaged in DC and centers its work around the needs of the community. You mentioned making sure that it's staffed appropriately to match the needs and desires of the community. As you consider the rising maternal mortality and morbidity rates and the unacceptable disparities, from your perspective, what are the unique attributes of the value add of the community-based birth center model that's linked to an FQHC in addressing birth equity?
So I would start off by saying, first of all, the option to have out-of-hospital birth is not as broad as most people think. Out of our 350 birth centers, maybe 10 accept Medicaid, Amy?
Mm-hmm.
Not a lot.
Yeah, it's low. That's sad if it's that low, but it's quite low. Most birth centers honestly just opt out entirely of Medicaid because there's no
reimbursement.
They lose money. They literally lose money with each patient.
Exactly.
Yeah.
And so from an equity standpoint, being able to offer this option is huge. As a out-of-hospital birth midwife, I can tell you that it's transformative to a lot of birthing individuals' experience and life-changing. And so being able to access into that for this life transition is huge. I think that what I like about our model, why I feel like it should be definitely replicated, because there were more FQHC birth centers before, lots of different reasons for why the numbers have gone down to 5. But why I would push for it to grow is that it's an opportunity to be way more patient-centered with the care coordination. And financially, it's a lot smarter. And it's just a lot easier for our families. It's one stop shop.
Mm-hmm.
You know, being able to say, all right, I can go here. Not only can I get my prenatal care, I can also get some basic therapy. I can also get dental. We now have a care coordinator that links us between the health side to the housing side. We need to create more spaces that are just one place, because that's a huge barrier. A lot of times with a lot of our health systems, the fragmentation, the hurdles they have to jump through, who's accepting which version of insurance, or this location doesn't allow this. And so going away from creating these barriers for families who are disenfranchised, that I feel like is really what's needed. Patient-centered, very much so if possible, culturally congruent, and also not systems that are not punitive.
Mm-hmm. You know, the benefits of a birth center within the FQHC model, when you think about the Medicaid population and having all of those wraparound services, you mentioned, you know, the behavioral health, dental, housing, and there's just so much more that the FQHC provides in addition to the birth center option and support that's provided. And I can't help but wonder, why isn't this model being replicated across the US? And I suspect that there are significant challenges and barriers that are impeding that progress. So I'm hoping that maybe you could shed some light on what some of those barriers might be, and helping us understand why this birth center FQHC model hasn't been embraced and replicated.
You just heard Amy break down all the different challenges of just having a birth center, the state's regulations, what is required for a birth center accrediting bodies, what's required for state's Department of Health. Like, a lot of these things are not connected. A thing that I really, really think that we also don't talk about is the challenges of maintaining midwifery's integrity in a FQHC system,
Mhm.
right? So, everybody kind of, you know, has their flow, and midwives can definitely align, but practicing true midwifery, it doesn't follow those rules. It's a lot more rules. So, I think another challenge is trying to figure out how to maintain midwifery's integrity, but there's a lot of benefits to being FQHC. And one of the biggest benefits, of course, is the malpractice coverage. That's a huge burden financially on practices survival. So, with that piece being taken care of, that's one huge reason why the model is worth being replicated. But I think it's a lot of things, a web to kind of detangle, to kind of get through. And we are DC's only freestanding birth center, but we also have to acknowledge the fact that for TNMs, the regulation, midwives have a lot of autonomy in DC,
Mhm.
unlike a lot of places, and have for a long time, for a very long time. So I always hear from people all the time, like, "Oh, you're at a birth center. It's really easy." It's not easy, and like we haven't even gotten to the complexity of like what it is for clinical practice guidelines, to drills, to who's your backup, who's your medical director, who does your state say your medical director is, staffing, the training, who has experience. We have all these different midwifery programs. Not everybody's getting out of hospital training. Most are getting hospital training. So there's a lot of different pieces, but I definitely feel like it's worth it. I definitely feel like we should push towards it. Um, Even things like figuring out appropriate funding for fellowships so that folks can have the opportunity to get out of hospital birth experience to a fellowship maybe after they graduate with an appropriate salary. I don't want to say that because a lot of people, grown people, have grown bills. So they can't, fellowships may not be an option for them just because they can't afford it. So I hope that wasn't a whole bunch of gibberish, but I'm just saying it's really layered, it's really complex, but it's worth it.
Thanks.
I can add something, and actually this would be a good time to bring up the slide. I think there's been a lot of work in the last year or so to create tools and programs to help people start birth centers. There's been a lot of players other than the American Association of Birth Centers, but I just wanted to make folks know, since part of this topic is on just what's involved in opening a birth center, that these are some of the resources. The American Association of Birth Centers is a really rich resource. They've got a whole program on how to start a birth center, which is online, but they also, when we don't have a pandemic going, do it around the country and in collaboration with different birth centers. We just developed, my company, Primary Maternity Care, just developed the onboarding training that was listed there. Yeah, there we go. So that's a set of just standardized onboarding training. So Ebony just referenced kind of the need to train up staff, and there's a lot of, the only way we're going to grow the birth center model is to move some midwives, at least in the short term, out of the hospital model and into this model. And you have gaps in what the skill set is, and also just it's a different environment. So a lot of gaps around newborn skills and stuff like that. So AABC provides a bunch of onboarding training, some of which we help develop, as well as different toolkits to get in compliance with CLIA, which is for like laboratory compliance, which we have to comply with, EMS coordination. So there's a whole bunch of work that birth centers need to do to get transport
Transfers.
out. Yeah,
Yes.
that's a
Mhm.
big project, and it involves people that don't necessarily want to work with you and collaborate with you, but it's super important and it's really critical for safety. So we developed that toolkit for them as well. And there's contracting toolkits and so on. So it is a huge, crazy web, and always takes way longer than people who are trying to start birth centers expect to. The statistic I've said many times in New York, the last birth center that opened there took 7 years to open, and we accomplished Jazz in about 7 weeks. So obviously, when the path is cleared and everybody kind of agrees that it's an important thing to do, it can be done quickly, not overnight, but quickly. But having tools and toolkits and people who kind of know the ropes really does help.
Thanks for adding that. And Karen has been monitoring the Q&A box, and I know that folks have been submitting questions for you during the session and has started to consolidate their questions for you. Karen, you want to share with us a question or two that we can start to kick off the participant Q&A?
Absolutely. I have a couple of questions for Ms. Marcel. Ms. Marcel, you mentioned that 8 of 10 midwives at Community of Hope are Black, Indigenous, and people of color, meaning BIPOC. We've had a couple of questions around what does that acronym mean. Can you tell us, was there an intentional effort to recruit BIPOC midwives into the practice? If so, can you talk more about that effort?
Absolutely. Yeah, that was definitely intentional. And so what I said was why the recruitment was a little bit easier for someone like me is because I have really worked hard, relationships, networking, mentoring. There are a lot of folks that I took the time when they said they were interested in becoming a midwife, and whether it was answering an email or a phone call and just chat with them that one time and just stayed in contact with them as they went through the journey to midwifery school and then working afterwards. But mentorship has been very, very helpful in connecting to different individuals. And a lot of folks, it's hard for non-BIPOC providers sometimes when I say that to be like, well, why? Like I provide, just, good care as well. And that's not what it's about. It's not about your skill level or the quality of care that you can provide. It's about having the conversation about trust with medical systems, history, harms that have been done, racism, and wanting to be a lot more comfortable when you're having your interactions, not having to code switch. Code switching is exhausting. And when you are vulnerable trying to receive care, the last thing you want to do is code switch the whole time. And so I think it's been really, really helpful to stay in contact with people that I mentor, students. Everywhere I work, I am adamant about students. Bad enough, we really don't have the supply to meet the demand. There's still students struggling to get clinical sites, but trying to make sure that I have the opportunity to grow midwives, and realizing that it was a huge priority. But like I said, 5 years ago, I couldn't say to, my leadership, so I think we should have Black midwives. And I bet you if we have Black midwives, more people will come. I couldn't say that to them, because automatically walls go up and folks are kind of defensive. But that's what I mean about them being able to kind of trust me. And I would say, hey, I'm going to do things not really textbook, just trust me. I know what I'm doing. Now we have research that shows the benefits of having cultural congruent care. And so now I have that to kind of throw out there in my discussions, but it was very, very, as a matter of fact, the best way to say it is, one of my mentors, Dr. Joy Perry, said to me one time, people are always asking you how you did something when it was just intuitive. I can't really tell you. I just knew in my spirit that's what needed to happen, and so I made it happen.
You did indeed. You did.
And now we're all trying to figure out how to replicate it.
Okay, I have another question for you that's sort of changing directions a little bit. But
Okay.
Ms. Marcel, you mentioned that the birthing center was acquired by Community of Hope. What made the birth center attractive for acquisition? And on the other side, why did the birth center consent to being acquired?
So that is a hard question to ask. Well, hard question to kind of answer. I think the most politically correct way to say it is that, like a lot of birth centers, they had a lot of different challenges, whether it be with infrastructure, finances, and needed help.
Mhm.
And I believe that Community of Hope saw it as an option to expand what they can offer. I do believe our leadership is has a pretty broad vision. Funny enough, I had a conversation with our CEO a couple of weeks ago, and she just never fails to surprise me on how broad she's willing to go. But I think they just saw an opportunity to broaden what they can offer.
Mhm.
Some of the leadership had their own personal experiences with midwives and knew the value of midwifery care and how beneficial it could be to add it. Yeah, pretty much. I think that the birth center pre the merger went through a lot of the challenges that a lot of birth centers face with
Mhm.
infrastructure and also finances.
Mhm. Mhm. Well, there definitely must have been something about the operations of the birth center that made it attractive for acquisition, despite the number of barriers that you were experiencing. So thank you very much. Now, Amy, I'm going to turn to you. There are a lot of questions about the startup for the Jazz Birth Center. Here's one. What was the lever that really convinced transferring hospitals to enter into a memorandum of understanding with the Jazz Birth Center? Many institutions are seen as not being really friendly to community birth centers, and something happened there.
Yeah, I think the lever was the political pressure and the political visibility of the commission or the committee, whatever it was. And so I think, the hospital that we worked with is Mount Sinai West in Manhattan, and the requirement of the regs is to have a written transfer agreement. So they're agreeing essentially to take the patients that need to come over, and they have a whole obviously program of doing that because they're a big health system and have people transferring from other facilities or outpatient settings. So they came really right to the table and were very collaborative and cooperative. And again, I think it was the unique political situation and the visibility of all of this. But I also think it was, it was evident that to them, it just fit right in with kind of a process that they've had to design and implement for all kinds of health service lines. And so sometimes I think we have this exceptionalism around maternity care that nobody's ever had to kind of solve these operational issues or had, and so it was relatively easy to get it together. It's not, I'm no longer involved in that birth center because I was just on a short-term contract with them. There always are issues around the relationship, and it's really important to be able to build relationships between the birth center based staff and the hospital staff to debrief transfer. So we did that as well. We had actually our very first admission ended up transferring, and the first few that we had, we all got on the phone and kind of talked through what went well, what could have gone better, how can we tweak the process. So yeah, but I think that ultimately was the lever, and people acted like professionals, and so we got it done.
Mm-hmm, mm-hmm. And here's a follow-up question. We have on the call many individuals representing state Medicaid agencies and health plans. And you mentioned earlier on that very few births that occur in birthing centers are covered by Medicaid. What can state Medicaid agencies and health plans do in order to be more supportive of this birthing option for women who are covered by Medicaid?
I think looking again at the contracts, making sure the pricing is adequate and that claims are being processed appropriately. Because there aren't standards, there also can just be a higher rate of kind of claims that take a longer time to get paid because of setting up those systems. But, you know, I think there, particularly with MCOs, there's a lot of opportunity to be flexible in how you pay for care. There's one of the big things, and it ends up having a big impact on the financial viability of a birth center, is how transfers are treated. So people that are admitted into the birth center but need to go to the hospital for one reason or another and deliver there. But depending on the contract, you could get anything from no facility fee at all to your full facility fee. And obviously higher is better for birth centers, but you don't want there to be, first of all, a financial disincentive to transfer patients when it's medically appropriate, but also the value of the model. Some of it obviously is in the birth care, but a lot of it is in the prenatal care, and the outcomes from Strong Start, which I know participants are familiar with. You know, the big one was a reduction in in preterm birth, which has nothing at all to do with the facility. That has to do with the prenatal care and all the integrated services and care coordination and just the relationship-based approach. And birth centers end up subsidizing that care with the facility fees that they get, or just, you know, having philanthropy fill in the gap, or what the various ways that birth centers make it work. So I think just a shifting of the payment to the prenatal and postpartum time, or making sure that those rates are appropriate. Part of that is making sure you're paying midwives the same as physicians. There's a lot of states, including mine, that for whatever reason decide the same visit is worth 85% if a midwife does it. So that when your whole model of care is midwifery care, and every visit that's done is a midwifery visit, then suddenly that's 15% of your overall, versus, you know, a practice that can maybe absorb that because they have a multi-specialty model or provider model. So those are some of the levers I can think of. Ebony, you have anything to add?
Yeah, I was just gonna say, like, even reimbursing birth center as well is still a lot cheaper than the hospital. And then,
Yep.
you know, having the midwifery model of care that has proven outcomes to reduce preterm birth. How much is it a day in the NICU? Probably 10 years ago, it was 10,000 a day. It's a lot more now. And so, you know, definitely looking at reimbursement. Also, being open to mixed models, open models, you know, whether it be in some states, there are home birth midwives that may use different birth centers, taking away barriers for that. CPMs, having all pathways have access and paying all pathways appropriately. Those are some of the things that definitely they can help with.
All right. Well, Jennifer, I know you want to move things along, but I do just want to say, if you could answer in 15 seconds, many health plans and state Medicaid agencies are really stymied with the contracting process because birth centers are different. They're not hospitals. They're not provider practices. They're not ambulatory care centers. And developing relationships is so important for birth centers and these other entities. What have you done to develop those relationships? Quickly.
They have come by and I've showed them the birth rooms. We've talked about what our model looks like and what we do. I still don't feel like it sticks. It doesn't stick enough. Or they're sending me the very junior people at the bottom. I'm not seeing the biggest and the highest of the pyramid.
Okay, and Amy?
Yeah, I was not directly involved in kind of payer relationships for most of the time I was at Baby & Co, but we, you know, getting people in the space and to be able to see it and meet midwives goes a long way to helping them understand the model of care. And I think just those are really one of the lessons learned, I think, is those are relationships you need to continue to tend. It's not just about when you're setting up the contract, because you can always find a champion for this model in every health plan around the country, and they can really help you get things going. But they'll go and, take another job someday, and you need to kind of continue to do the education. And a lot of it is like basic education. So programs like this whole curriculum are going to be helpful to just have archived. So everybody's at a little bit of an elevated knowledge level about the model, and you can get more quickly into how we're going to get this paid and make it work for all parties.
Thank you so much. Jennifer, thanks for indulging.
Yeah, on that was a great final question, and I want to thank you for sending that. Just want to remind everyone, please, if you still have questions, send them in through the Q&A chat box. We will be sending all of them to our panelists, and we'll collate their written responses in a Q&A document that will go out with the post-session materials. Ms. Romano, Ms. Marcel, I cannot thank you enough. This was an incredible conversation today. Your leadership, your thoughtfulness, your trailblazing ways, your innovators, you are on the ground making this happen, and you're inspiring everyone. You've given all of us so much food for thought and encouragement. And I said, again, inspiration that this can be done. I can't thank you enough for your time today and participating in this session. I'm going to hand it off to Chloe to do a few wrap-up items before we close out today.
Thanks, Jennifer, and thank you to our panelists. At this time, everyone should have received an email with the link to complete today's session evaluation. I've also dropped a link in the chat. Today's session evaluation is extremely important, as it will be used to determine the topics and content for the last two sessions. The proposed topics are here on this slide. The evaluation will take less than 5 minutes to complete. If you did not receive the email with the session evaluation, please contact me. My email is listed on this slide. We will be sending the presentation slides, session Q&A document, and archived recording of today's session by email to you within the next 2 weeks. Finally, our next session is scheduled for February 12th and will be focused on aligning state Medicaid initiatives with midwifery-led models of care. Keep an eye out for that pre-session email with the agenda and required pre-session activities. And if you haven't already, please remember to add Jennifer's email to your contact list to ensure that the series emails are not sent to spam. Her email is also posted on the slide. Thank you again for your participation, and we look forward to seeing you at our February session.
Thank you, everyone.
Thanks, everyone. Thanks, IMI team. Take care.
Thank you.
Thank you.